When you hear the word gout, I am willing to bet a very specific, almost comical image pops into your head.
Oh, absolutely. It is usually a wealthy Victorian aristocrat or, maybe an old king sitting on a throne.
Right, he has got this massive roasted turkey leg in one hand, a heavy goblet of wine in the other.
And his foot is propped up on a plush velvet stool, right? Because he is suffering from the infamous rich man's disease.
Exactly. But today, we are completely throwing that dusty stereotype right out the window.
We really are, because it is arguably one of the most persistent and frankly misleading stereotypes in all of medical history.
Yeah, I mean, we have spent centuries culturally categorizing this condition as just this medieval affliction born out of gluttony, just the lack of self-control.
Which is completely unfair to anyone actually dealing with it.
Totally. So for this deep dive, we have gathered a fascinating stack of clinical pharmacology research and detailed medical source notes that just shatter that old narrative entirely.
The science here is just incredible.
It really is. Our mission today is to rescue this condition from its reputation as a medieval punchline and show you, the listener, what is actually happening. Because gout is not about eating too much rich food.
Not at all. It is a dynamic, intensely localized, and highly destructive chemistry experiment happening right inside the human body.
Which sounds terrifying, but we are going to explore that microscopic chemistry.
Yeah.
And more importantly, we are going to unravel the incredibly specific, two-pronged pharmacological strategy required to defeat it.
Which is absolutely crucial. I mean, managing this condition requires us to understand how we so frequently get it wrong in the clinic.
Right, because the way modern medicine treats gout involves two genuinely different types of drugs working on completely different biological mechanisms, right?
Exactly. And as our pharmacological sources highlight again and again, confusing these two sets of drugs is the single most common clinical and conceptual error in this entire field.
So let's unpack this, because before we can even talk about those drugs, the chemical solutions to the problem, we have to establish what the problem actually is.
We have to look at the root cause.
Yeah. And to do that, we have to look backward at human evolution. We have to look at why we, as a human species, are uniquely cursed with this condition compared to, well, the rest of the animal kingdom.
It is such a strange evolutionary quirk. Our sources point to a literal biological missing link.
So where does it all start?
It all begins with a fundamental biological process called purine metabolism.
Okay, purine metabolism. Walk me through that.
So to understand this, we need to know what purines actually are. They are essential chemical compounds, essentially the building blocks of DNA and RNA.
So they are everywhere.
Everywhere. You have them naturally occurring inside every single cell in your body. When your cells reach the end of their life cycle and break down, those internal purines are released.
Okay, so our bodies make them, but we also eat them, right?
Yeah, we take in exogenous purines from our diet, especially from eating the muscle tissue of other animals or from, yeast-heavy products like beer.
Right, so our bodies are just constantly breaking down these purines, both from our own dying cells and from the food we eat.
Yes, and as the body breaks them down, it uses a specific enzyme called xanthine oxidase to process them.
Xanthine oxidase.
Exactly. And the final end product of that processing, the chemical exhaust fume, essentially, is a substance called uric acid.
And here's where it gets incredibly interesting, especially if you look at like a dog or a horse or almost any other mammal out in the wild.
Right. For them, producing all this uric acid is not a problem at all.
Because they have a built-in biological mechanism to handle the exhaust.
They do. They possess a highly functional enzyme called uricase.
Uricase.
Right. What uricase does is it steps in right at the end of the line. It takes that uric acid and chemically breaks it down one step further into a compound called allantoin.
And allantoin is better.
So much better. The beauty of allantoin is that it is highly water-soluble. It dissolves effortlessly into the bloodstream, travels to the kidneys, gets filtered out, and is just flushed away in urine without causing any trouble whatsoever.
Okay, I try to picture it like a kitchen sink.
Oh, I like that.
Yeah, so most mammals have this heavy-duty garbage disposal installed underneath the sink. That is the uricase enzyme. They dump their metabolic waste in, the disposal grinds it down into a fine, soluble liquid, and it just washes away perfectly.
That is a great way to visualize it.
But humans we just don't have the disposal installed.
We truly don't. Somewhere along our evolutionary timeline, millions of years ago, the specific gene that codes for the uricase enzyme mutated.
It just broke.
It effectively turned off. So because we lack a functional uricase enzyme, our metabolic assembly line stops abruptly at uric acid. We cannot convert it into that easily flushed allantoin.
So because we are missing this disposal, our bodies are just forced to hoard the chemical trash.
Essentially, yes.
We just walk around with higher levels of uric acid in our blood than other animals do.
Right. Uric acid is notoriously poor at dissolving in fluids, so human beings, simply by existing and metabolizing our own DNA, naturally carry a much higher, less soluble uric acid burden in our serum.
But having a higher concentration of a chemical floating around in your blood, that is one thing. That sounds like a silent, invisible problem.
It is until it is not.
Right, so how does a silent buildup in the blood suddenly transform into the agonizing localized joint pain that defines this disease?
Well, the transition from a silent buildup in the blood to a screamingly painful joint is not driven by a biological infection or a virus.
Okay.
It is driven purely by the laws of physics. It all comes down to saturation, concentration limits, and temperature.
Oh man, take me back to physics class. How does that mechanism actually work in the human body?
So there is a very strict physical threshold for uric acid in human blood at normal body temperature. When the concentration of uric acid crosses roughly 6.8 milligrams per deciliter, it hits a hard physical limit.
6.8 milligrams.
Exactly. The serum, the liquid part of your blood, simply cannot hold any more of it in a dissolved state. At 6.8, the blood becomes supersaturated.
Wait, I want to make sure I'm visualizing this correctly. Is this literally like the rock candy experiment from middle school science class?
Oh, the sugar and the string.
Yeah, exactly. You know, the one where you take a beaker of hot water and you keep stirring sugar into it until the water is completely saturated and cannot absorb a single grain more.
Yeah.
And then when that beaker cools down even a few degrees, suddenly, bam, the sugar precipitates out of the water and these sharp crystals start growing on the string.
That is a phenomenal analogy because the underlying mechanism is identical. Once you cross that 6.8 threshold, the joint fluid is supersaturated.
Wow.
And just like your beaker of sugar water, temperature plays a massive role in whether those molecules stay dissolved or turn into solid crystals. In the cooler parts of your body, the solubility limit of uric acid drops even lower than 6.8.
Which perfectly explains the most famous target for a gout attack, the base of the big toe.
Absolutely. Think about the geography of the big toe. It is the most peripheral joint in the body.
It is super far away from the heart.
Right. It is far away from the warm core of your chest and abdomen, meaning its baseline temperature is significantly cooler.
That makes so much sense.
Plus, the big toe joint experiences constant mechanical stress from walking, which makes the microenvironment slightly more acidic.
Oh, I did not think about the acidity.
Yeah, and finally, it is less perfused. It simply does not have the same robust, rushing volume of warm blood flow as a major joint, like, say, the hip or the shoulder.
So it is just the ultimate hostile microenvironment. You have the supersaturated fluid hitting a cool, acidic, poorly perfused pocket, and the uric acid just nucleates.
It precipitates right out of the fluid and turns solid. It forms solid crystals of monosodium urate, or MSU for short.
And I'm guessing these are not nice, smooth, pebble-like crystals.
Oh, not at all. If you look at them under an electron microscope, they are violently sharp, needle-shaped structures.
Just the thought of that.
Imagine microscopic spears or shards of glass suddenly materializing out of thin air and embedding themselves into the delicate lining of your joint.
That sounds absolutely excruciating. And obviously, the human body does not just ignore a sudden influx of microscopic glass shards in a joint.
Far from it. Your immune system's job is to patrol the body for foreign invaders. When specialized white blood cells called macrophages detect these needle-like structures, they attempt to clear them out.
By eating them.
Yeah, by swallowing them. But they cannot digest these sharp crystals. The crystals often physically pierce the macrophage from the inside out, literally killing the immune cell.
Oh, wow. So the immune cell actually dies trying to eat the crystal.
Yes, and as the macrophage dies, it bursts open and releases this massive flood of chemical alarm signals called cytokines, specifically one called interleukin-1 beta.
Interleukin-1 beta, okay.
And this chemical alarm summons thousands of other immune cells to the joint. The blood vessels dilate to let them all in. The area becomes red, incredibly swollen, hot to the touch, and exquisitely painful.
And that cascading inflammatory war zone is what the patient experiences as an acute gout attack. This completely reframes how we have to think about diagnosing the disease. If the true root cause is this invisible, localized chemical precipitation, that changes everything.
Yeah.
We cannot just look at a swollen foot, blame the turkey leg, and call it a day.
And the clinical guidelines have undergone a massive shift because of this realization. For centuries, gout was a purely clinical diagnosis based on observation.
Right, the doctor just looks at it.
A doctor would observe a red, hot, tender big toe, maybe ask the patient if they had been indulging in rich foods or drinking port wine, and confidently declare a diagnosis.
The classic Victorian novel approach.
Exactly. But modern rheumatology has completely abandoned that observation-based stereotype. The gold standard definition of gout is now strict and crystal-based.
So they have to find the crystals.
To definitively diagnose gout, a physician has to physically prove the presence of those monosodium urate crystals in the joint space.
How do they actually do that? I was reading the source notes, and they got highly technical about lab equipment and lighting. Can you break down what the lab technicians are actually looking for?
Sure. So a doctor will use a needle to draw a tiny sample of fluid directly from the swollen joint. They send that fluid to a lab where a technician examines it under a very specific tool called a polarized light microscope.
Okay, polarized light.
Yeah, and under polarized light, these monosodium urate crystals display a highly distinct optical property. They appear needle-shaped, and they are what we call negatively birefringent.
Hold on. Negatively what? That sounds like a cloaking device from Star Trek or something. Break that down for me. What does negatively birefringent actually look like through the lens of a microscope?
It sounds complicated, but birefringence just refers to how a material bends or refracts light.
Okay.
When you shine polarized light through these specific needle-shaped crystals, they interact with the light waves in a highly predictable way. If the needle crystal is lying parallel to the axis of the polarized light, it will glow with a bright fluorescent yellow color.
Yellow, got it.
But if you rotate the crystal perpendicular to the light, it turns blue.
Oh, that is wild.
That specific color-shifting property, yellow to blue, is the definitive visual fingerprint of monosodium urate. If you look through the lens and see those glowing yellow needles, there is no debate. You have gout.
This raises a massive question for me, and I'm sure you listening are wondering this too, based on what we just learned about the physics.
What is that?
If humans naturally have higher uric acid because we lack that uricase garbage disposal, and if crossing that 6.8 threshold is what allows the crystals to form, are you telling me someone can have sky-high uric acid levels in their blood and never actually get the disease?
That is exactly what I'm telling you.
Does it truly take that specific rock candy trigger in a cold joint for gout to exist?
You are hitting on one of the most critical clinical distinctions in this entire deep dive. Having high uric acid floating in your blood is a condition called hyperuricemia.
Hyperuricemia.
But hyperuricemia and gout are not synonyms. They are not the same disease.
That is crazy to me. So you can just walk around with supersaturated blood and be totally fine.
There are millions of people walking around right now with a massive uric acid burden in their serum, well above that 6.8 threshold, who never form a single crystal and never suffer an attack in their entire lives.
Wow.
Their bodies simply tolerate the supersaturation without the chemical precipitating out. Gout only officially exists when that physical precipitation happens, the glass-like needles form, and the immune system launches its violent, painful attack.
Which brings us to the ultimate core of our mission today, the pharmacological battle plan.
Yes, the drugs.
Because if having dissolved uric acid in your blood and having active needle-shaped crystals triggering an immune war in your joint are two completely different physical states, then it makes perfect sense that treating this disease requires two entirely distinct sets of tools.
And confusing those two tools is where patient care goes terribly wrong. Treating gout is essentially two opposite jobs. You have drugs designed for the acute attack, and you have urate-lowering therapies, widely referred to as ULTs.
I want to introduce an analogy here to help us lock this concept in, because when I was reviewing the pharmacology notes, thinking of it this way made the complex chemistry finally click for me.
Let's hear it.
Imagine dealing with a house fire that was caused by a gas leak.
Oh, I like this visualization. Let's trace it out.
Okay, so you have a broken gas pipe, the living room is full of gas, a spark hits, and suddenly the house is engulfed in flames.
Right.
The acute attack, drugs, medications like colchicine, NSAIDs like ibuprofen, or injected corticosteroids, those drugs are the fire extinguishers.
Exactly.
Their only job in the body is to put out the flames of inflammation. They stop the burning, agonizing pain caused by the crystals that are already present in the joint.
Yeah.
But, and this is the crucial part, they do absolutely nothing to the uric acid levels in the blood.
Nothing at all.
They put out the fire, but they do not fix the underlying gas leak.
The fire extinguisher analogy is perfect for understanding their pharmacological limits. Take a drug like colchicine, for example.
Yeah, what is the deal with colchicine?
Well, it is actually one of the oldest medicines in human history, derived from a flower called the autumn crocus.
Wait, really? A flower?
Yeah. And when you take colchicine during a flare-up, it does not dissolve the crystals. Instead, it enters your white blood cells and prevents them from building their internal cellular scaffolding, which are called microtubules.
Wait, it literally stops the immune cells from building scaffolding.
Yes. Without those microtubules, the white blood cells are essentially paralyzed. They cannot travel into the joint to attack the crystals.
That is incredible.
So colchicine stops the fire by preventing the firefighters, the immune cells, from showing up and causing a scene.
Okay, what about the other acute drugs?
NSAIDs and steroids work differently by blocking the production of inflammatory chemicals, but the end result is the same. They suppress the immune system's violent reaction. They do not alter the chemistry of the uric acid.
Now, on the other hand, we have the urate-lowering therapies, the ULTs. These are drugs with names like allopurinol, febuxostat, probenecid, and pegloticase.
Yes, the ULTs.
If the acute drugs are the fire extinguishers, these ULT drugs are the plumbers. They are brought in to turn off the gas line. They actively reduce the body's overall uric acid pool.
That is their only job.
Over time, by dropping the concentration well below that 6.8 threshold, they stop new crystals from forming. Eventually, they even allow the existing crystal deposits to dissolve back into the blood and get washed away.
Which is the ultimate goal.
But here is the massive catch. The plumbers do not fight fires. ULTs do absolutely nothing to treat pain or stop inflammation.
And this is where we have to look closely at the pharmacological mechanisms of these plumbers, because they achieve this goal in fascinating ways.
Like how?
Let's look at allopurinol, which is the most commonly prescribed ULT. Remember earlier we talked about xanthine oxidase, the enzyme that manufactures uric acid?
The one on the metabolic assembly line, yeah.
Right. Allopurinol is a chemical mimic. It looks so much like a purine that the xanthine oxidase enzyme accidentally binds to it. The enzyme gets stuck, completely jammed up by the allopurinol, and can no longer produce uric acid. Production shuts down.
So allopurinol literally turns off the faucet. What are the other drugs?
Well, probenecid takes a different approach. It works directly on the kidneys. Normally, your kidneys filter out uric acid, but then reabsorb a lot of it back into the bloodstream.
Why would they do that?
Just biological recycling. But probenecid blocks that reabsorption, forcing your body to pee out massive amounts of the uric acid.
Oh, wow.
And then there is pegloticase, which is an intravenous drug reserved for the most severe cases. It is literally a synthetic version of that uricase enzyme, the biological garbage disposal that humans lost in our evolution.
No way. We just put the disposal back in.
We just inject the missing enzyme directly into the patient to dissolve the burden.
That is amazing. So a fire extinguisher cannot fix a broken pipe, and a wrench is not going to put out a blazing fire. You need both, but for entirely different reasons.
Precisely.
If a patient limps into the clinic with a swollen, agonizing toe, handing them a plumber's tool like allopurinol won't do a single thing for their immediate pain. They need colchicine, or a steroid, the fire extinguisher, to paralyze those white blood cells and shut down the active inflammation.
And the clinical error happens when patients try to take their daily allopurinol to fix a sudden flare, or conversely, when they just pop ibuprofen for a week, feel better, and think they have cured their gout, ignoring the massive chemical gas leak still building up in their blood.
Which brings us to an incredibly counterintuitive reality in gout treatment. Our sources dedicate an entire section to this, calling it the treatment paradox.
It is so tricky to navigate.
It turns out the timing of when you send the plumber into the house is incredibly dangerous.
It is the single most frustrating aspect of managing this disease for patients, and it is a major reason why adherence to these highly effective daily medications can be so poor.
Walk me through this paradox. Because if a drug like allopurinol lowers the bad stuff in the blood, if it fixes the gas leak and reduces the overall uric acid pool, why do the pharmacology warnings state so clearly that starting a ULT can paradoxically trigger an acute agonizing gout attack?
It sounds totally backwards, right?
Shouldn't lowering the uric acid make you feel better right away?
It seems like it should, but we have to look at what is happening on a microscopic chemical level inside the joint. Imagine the crystal deposits that have been sitting in the joint for months or years.
Okay, the rock candy.
Right. They have formed a solid mass, almost like a block of ice. Over time, the body tries to protect itself from these sharp edges by coating the crystal mass in specific proteins called apolipoproteins.
Apolipoproteins.
Yes. These proteins act like a blanket, hiding the dangerous crystals from the immune system. As long as the uric acid levels in the blood remain high and steady, that protein-coated block of ice stays stable and dormant.
So you have these dormant little shards hiding under a protein blanket, doing no immediate harm.
Correct. But then you introduce the plumber. The patient starts taking allopurinol. Within days, the uric acid levels in the blood begin to plummet.
Yeah.
This sudden drop creates a steep new concentration gradient between the joint tissue and the blood. The fluid surrounding the joint is no longer supersaturated. So what happens to our solid block of rock candy when the surrounding fluid is no longer saturated?
Oh, I see. It has to start dissolving back into the liquid.
Exactly. Over the long term, dissolving the crystals is the ultimate goal. But in the short term, as that solid mass begins to shrink and dissolve, its structural integrity destabilizes.
Its blanket falls off.
The mass breaks apart. It sheds that protective protein blanket. And suddenly, thousands of freshly exposed, naked, microscopic needles are dislodged and shed directly into the joint space. And the immune system's macrophages, which have previously ignored the stable, hidden deposit, suddenly see this massive shower of sharp foreign objects and instantly sound the alarm.
And the cytokines flood in, the blood vessels dilate, and boom, a brand new, agonizing attack, brought on entirely by the medication designed to cure the disease.
By using the plumber's wrench at the exact wrong time, by violently shifting the chemical balance while the fire is still smoldering or the crystals are delicately balanced, you re-expose the irritant.
That is just cruel.
It is.
Yeah.
This is precisely why modern clinical guidelines advise doctors not to start a drug like allopurinol right in the middle of an acute, raging attack. You have to wait until the fire is completely extinguished.
And even when they do start the allopurinol, don't they have to prescribe a shield along with it?
Yes. Standard practice is to prescribe the urate-lowering therapy alongside a low-dose fire extinguisher.
Okay, like what?
A doctor will often prescribe a low daily dose of colchicine or an NSAID for the first 3 to 6 months of allopurinol treatment.
3 to 6 months.
Yeah. This prophylactic shield serves to continuously paralyze the immune response, suppressing any flare-ups caused by the dissolving, shifting crystals, while the body slowly adjusts to its new, healthy chemical baseline.
You literally have to medicate against the biological consequences of your own medication. It is an incredibly delicate balancing act of internal chemistry.
It is, but the payoff is immense. If a patient can endure that initial transition period and adhere to the urate-lowering therapy, once all the old hidden deposits finally dissolve completely, the patient can be genuinely free of gout attacks for the rest of their life.
Wow. So what does this all mean for you, the listener, the next time someone makes an outdated joke about an old king eating too much turkey?
It means they are missing the real story.
The core takeaway from our dive into these medical sources is a total paradigm shift. Treating a painful flare and preventing the next one are two fundamentally different battles requiring completely different pharmacological weapons.
Two different jobs.
Right, one is about paralyzing a violent immune response to microscopic shards. The other is about altering your body's baseline chemistry to keep those shards from ever nucleating in the first place.
We have taken this condition from a medieval punchline and revealed it for what it truly is, a fascinating story of missing mammalian enzymes, strict physical thresholds of solubility, negatively birefringent needles glowing under polarized light, and a highly specific two-part pharmacological strategy.
Absolutely. Now, as we wrap up this deep dive, I want to leave you with one final provocative thought to mull over. A question that builds on the underlying biology we just discussed.
This is one of my favorite theories to talk about.
It is so interesting. We talked extensively about how humans are uniquely weird for having lost that functional uricase enzyme. We lost our biological garbage disposal, leaving us saddled with much higher uric acid levels than other mammals.
Right.
But evolution rarely does things entirely by accident.
No, it does not. The loss of that enzyme is currently one of the most debated questions in evolutionary biology. Why did natural selection allow that mutation to survive?
Think about it. Could this seemingly broken metabolism have actually provided our ancient ancestors with some hidden evolutionary advantage?
Some researchers certainly think so.
Yeah, some theorize that uric acid actually acts as a powerful antioxidant in the blood, which might have helped early humans fight off disease and live longer.
Which is a huge advantage.
And other evolutionary biologists suggest that higher uric acid levels helped our primate ancestors maintain their blood pressure during periods when dietary salt was incredibly scarce on the ancient African savanna.
It forces us to ask a really profound question. Is gout simply a metabolic error? Or is the pain of those crystals just the unfortunate modern tax we occasionally have to pay for a genetic mutation that thousands of years ago actually helped the human species survive a harsh environment?
It really makes you wonder. The next time you picture that Victorian king with his foot propped up on a velvet stool, maybe he was not just suffering from a life of excess. Maybe he was paying the evolutionary tax for human survival. Something for you to think about. Until next time, keep diving deep.